Hello and namaste to all of you. I'm Singh from Department of Physiotherapy and Diagnosis. And for today's lecture, I'll be discussing with you about ascites, which is one of the most common pathophysiology in case of a ascitic fluid accumulation. So ascites is the abnormal buildup of fluid in abdomen, and technically it is more than 25 ml of fluid in peritoneal cavity, and although volumes greater than 1 liter may occur, so symptoms may include increased abdominal size, increased weight, and abdominal discomfort, and shortness of breath. So complications may include spontaneous bacterial peritonitis, and in a developed world, the most common cause in liver cirrhosis and other causes cancer, heart failure, tuberculosis, pancreatitis, and blockage of hepatic vein. And in cirrhosis, the underlying mechanisms involves high blood pressure in the portal system and dysfunction of blood vessels. In diagnosis, is typically based on examination together with your ultrasound or a CT scan, and testing for fluid can help in determining the underlying cause. So, treatment often involves a low salt diet, medication such as diuretics, and draining the fluid, and transjugular intrahepatic portosystemic shunt may be placed but is associated with the complications. So, effect to the treat the underlying cause, such as the liver transplant, or may be considered. Of course, with of those with cirrhosis, more than half develop ascites in 10 years following diagnosis. And of those in this group who develop ascites, half will die within 3 years. So the term is from the Greek ascites, meaning bag-like. So the various signs and symptoms related to ascites is mild ascites is hard to notice, but in a severe ascites, it will lead to peritoneal distension. And people with ascites, they generally will complain of progressive abdominal heaviness and pressure, as well as shortness of breath due to mechanical impingement of diaphragm. And ascites is detected with physical examination of abdomen by visible bulging of flanks and reclining person, that is flank bulging, shifting dullness, a difference between percussion, note in flanks that shift when the person is turned on one side, and in massive ascites, the fluid thrill or fluid wave, a tapping or pushing on one side will generate a weak, a wave-like effect through the fluid that can be felt in opposite side of the abdomen. So other signs of ascites may be present due to underlying cause. For example, in portal hypertension, perhaps due to cirrhosis or fibrosis of liver, people may also complain of leg swelling, bruising, gynecomastia, hemostasis, mental changes due to encephalopathy, and those with ascites due to cancer, that is, or peritoneal carcinomatosis, may complain of chronic fatigue or weight loss. So those with ascites due to heart failure may also complain of shortness of breath, as well as wheezing and exercise intolerance. So the various complications related to ascites may include spontaneous bacterial peritonitis, hepatorenal syndrome, and thrombosis, and portal vein thrombosis and splenic vein thrombosis involve clotting, and blood affects the hepatic portal vein, and varices associated with splenic vein, and this can lead to portal hypertension and reduction in blood flow. And when a person with liver cirrhosis is suffering from thrombosis, it is possible to perform liver transplant unless the thrombosis is very minor. And in case of minor thrombosis, there are some changes of survival causing cadaveric liver transplant. And now the various causes from severe of ascites are basically serum ascites albumin gradient, and which is a high from high serum ascites albumin gradient, and low serum ascites albumin gradient, which I've discussed in earlier topic during ascitic fluid. So once again, So causes for high serum ascites albumin gradient can be cirrhosis, heart failure, hepatic venous occlusions, constructive pericarditis, and kwashiorkor. And for low serum ascites albumin gradient can be cancer, infections such as TB, and pancreatitis, serotitis, nephrotic syndrome, and in case of your hereditary angioedema. And other rare causes can be mixed syndrome, vasculitis, hypothyroidism, renal dialysis, and peritoneal mesothelioma, and abdominal tuberculosis, and mastocytosis. Now, there are various classes or three grades of ascites. So, grade 1 can be mild and only, which is a mild and only visible on ultrasound and or your CT scan. Grade 2, it can be detectable with flank or bulging and shifting dullness. Grade 3 ascites, it is directly visible and confirmed with fluid wave and thrilled rest. So, there are various treatments for the ascites. So ascites is generally treated while an underlying cause is sought. So in order to prevent complications and relieve symptoms and prevent further progression in people with mild ascites, therapy are usually as an outpatient, and the goal is weight loss of no more than 1 kg per day for people with both ascites and peripheral edema, and no more than zero point 0.5 kg for people with ascites alone. And in those with severe ascites causing tense abdomen, hospitalization is generally necessary for paracentesis. And treatment in high SAAG, that is in case of your transudate, it can be treated with a diet. So in diet, salt restriction is the initial treatment, which allows diuresis, that is production of urine. So since the person now has more fluid than salt concentration, so salt restriction is effective, and in about 15% of these people. So if a water retention is needed, so if a serum sodium levels, they drop below 130 millimoles per liter. In case they can be given diuretics. So since salt restriction is the basic concept in treatment, and aldosterone is one of the hormone that acts to increase salt retention. So a medication that counteracts aldosterone, it should be sought. So spironolactone or other distal tubule diuretics such as triametrine and amyloidride is the drug of choice, since they block the aldosterone receptors in your collection tube, and this choice has been confirmed in a randomized control trial. And diuretics are for ascites, they should be dosed once per day, and generally the starting dose is oral spironolactone 100 mg per day, and 40% of your people will respond to spironolactone. And for non-responders, a loop diuretics may also be added, and generally furosemide is added a dose of 40 mg per day and maximum 160 mg per day, or alternatively bumetanide or torazamide, which in the ratio of 100 is to 40, will reduce the risk of potassium imbalance and serum potassium levels and renal function. They should be monitored closely while on these medications. So, while monitoring diuresis, diuresis can be monitored by weighing the person daily, and the goal is weight loss for no more than 1 kg per day for people with both ascites and peripheral edema, and no more than 0.5 kg per day for people with ascites alone. And if daily weights cannot be obtained, diuretics can be guided by urinary sodium concentration, and dosage is increased until a negative sodium balance occurs. So a random urine sodium to potassium ratio of more than 1 is a 90% sensitivity in predicting negative balance, that is more than 78 millimoles per day sodium excretion. And diuretic resistance. So diuretic resistance can be predicted by giving 18 mg intravenous furosemide after 3 days without diuretics and on 80 milliequivalent sodium per day diet. So the urinary sodium excretion of over 8 hours and less than 50 milliequivalent per 8 hours predicts resistance. And if person exhibits a resistance of poor response to diuretic therapy, the ultrafiltration or aquapheresis may be needed to achieve adequate control of fluid retention and congestion. So, the use of such mechanical methods of fluid removal can produce meaningful clinical benefits in people with diuretic resistance and may restore responsiveness to conventional dose of diuresis. So next is your paracentesis. So in those with severe or tense ascites, therapeutic paracentesis may be needed in addition to your medical treatments. So as they may deplete serum albumin levels in blood, albumin is generally administered intravenously in proportion to the amount of ascites removed. Last option is your surgery. So, ascites, there is a refractory to medial therapy. Medical therapy is considered an indication of liver transplantation. And in United States, the MELD score, which can be calculated online, is used to prioritize people for transplantation. And a minority of people with advanced cirrhosis, they have recurrent ascites and shunts may be used. So typical shunt used for portacaval shunt or paritovenous shunt and the transjugular intrahepatic portosystemic shunt. However, none of these shunt have been shown to extend life expectancy and are considered to be the bridges to liver transplantation. And a meta-analysis of randomized controlled trials by the International Concrete Collaboration concluded that transjugular intrahepatic portosystemic shunt was more effective at removing ascites as compared with paracentesis. And however, people with transjugular intrahepatic portosystemic shunt developed the hepatic encephalopathy significantly more often. So the treatment for low SAAG or exudate, so exudative ascites generally does not respond to manipulation of salt balance or diuretic therapy, and repeated paracentesis and treatment of underlying cause is the mainstay of treatment. And it has been suggested that ascites was seen in punishment, especially for oath breakers among Proto-Indo-Europeans, and this proposed builds to the Hittite military oath as well as various Vedic hymns. So this similar curse dates to Kassite's dynasty in 12th century BC. So that was all about ascites. So if you have any doubts or any queries, you can contact me. And until then, take care and thank you.